السلام عليكم. هذه محاضرة موجهة لطلبة الصف الرابع كلية طب الكندي بجامعة بغداد. عنوان المحاضرة هو The Prostate and Benign Prostatic Hyperplasia. يقدمها لكم الدكتور حارث محمد قنبر، أخصائي جراحة المسالك البولية بكلية طب الكندي. المحاضرة راح نحكي بها عن 2 topics. الأول هو The Prostate، الثاني هو Benign Prostatic Hyperplasia. What is the prostate? The prostate is a fibromuscular and glandular organ lying just inferior to the bladder. Normally it weighs around 20 grams and contains the posterior urethra, which is about 2.5 cm in length. It starts development during the fetal life at the 12th week of fetal life under androgen effect from the fetal testis. According to the classification of loosely, the prostate is divided into 5 lobes: anterior lobe, posterior lobe, right lateral and left lateral lobes, and a median lobe. Another classification that have more functional and pathological impact and depends more on embryological development of the prostate was developed by McNeil. McNeil divides the prostate into 4 zones: the peripheral zone, or the transitional zone that surrounds the urethra proximal to the entrance of the ejaculatory duct, the central zone that surrounds the ejaculatory duct, the peripheral zone that surrounds both zones and the prostate and the rest of the urethra, of the prostatic urethra, and the interior fibromuscular cytoma, which is generally a fibromuscular zone. It contains scarce or no glandular tissue. The peripheral zone is anandrogen dependent, while the central zone is non-androgen dependent. Therefore, castration of the baby before puberty leads to failure of a gland development. So the effect of androgen on the prostate development is documented. The blood supply of the prostate, arterial supply, comes from the inferior vesical artery, internal pudendal artery, and the middle rectal or middle hemorrhoidal artery. The venous drainage goes to the periprostatic plexus, which has connection with the deep dorsal vein of the penis, and the internal and it drains to the internal iliac or hypogastric veins. The prostate have sympathetic and parasympathetic nerve plexuses, and lymphatics from the prostate drains into the internal iliac, which is the hypogastric lymph nodes, to the sacral, to the vesical, and to the external iliac lymph nodes. Now this is about the prostate. Now we are going to talk about benign prostatic hyperplasia. Regarding the epidemiology of benign prostatic hyperplasia, it usually occurs in men after the age of 50 years of age, most often between 60 and 70 years. It is rare in Negro and very rare in Japanese. Why does it happen? Why does the benign prostatic hyperplasia occur in males? It may be due to discrepancy between androgen and estrogen ratio. With aging, the androgen decreases and leads to reversible changes of the androgen-estrogen ratio. This leads to relative increase in the estrogen that increases the periurethral gland proliferation. Another theory thinks that there is deregulation of the cell death and apoptosis, leading to imbalance between cell death and proliferation, and increasing the mass of the prostate. Regarding the histology, the prostate, as we said previously, composed of glandular tissue and fibromuscular tissue. So the term BPH refers to a well-defined histological changes characterized by slowly progressive nodular hyperplasia of the periurethral transitional zone. The adenoma may be of the epithelial type. The epithelial tissue may be predominant, or of the fibrous type with a dominant fibrous tissue, or mixed fibromuscular adenoma. The size of the enlargement that occurs in nodular hyperplasia is unrelated to the degree of obstruction. The smallest prostate may cause the worst outflow obstruction when it is fibrosed and embrace the outflow of urine. It can cause severe obstruction. On the other hand, a huge prostate may cause no obstructive symptoms if it expands to the outside. What happens when the prostate enlarges? The pathophysiological changes that occur when the prostate enlarged, they affect the urethra, they affect the bladder, and they affect the upper tract. Regarding the urethra, when the prostate enlarged, the urethra become longer, and it would become compressed from side to side, and this make it longer and narrower. The bladder over time, with overflow obstruction, will develop certain changes. These include, first, trabeculation, which is a prominence of the detrusor fibers observed through a cystoscopy, and this is named as an increased trabeculation. It is a manifestation of increased collagen deposition of the bladder wall. This finding is often associated with outflow obstruction, but may also be seen in unobstructed bladder. For example, in patients with enuresis, neurogenic bladder dysfunction, and idiopathic bladder instability. And as I said, during cystoscopic examination, the interior of bladder will appear trabeculated. Other pathophysiologic change in the bladder will be cellule formation. With extreme degree of trabeculation, the mucosa become pushed between the muscle fibers of the bladder wall to form small pockets called cellules. Herniation of the vesical mucosa through the detrusor muscle, forming a diverticuli, may occur in severe cases. It diverticuli constitutes an protrusion of the bladder mucosa outside the fibromuscular lining. Because of stasis of urine within the diverticulum, they are likely to harbor infection, stones, and urothelial cancer. A diverticulum near the ureteric orifices may cause vesico-ureteric reflex. The presence of bladder stones is a strong evidence of long-standing bladder outflow obstruction. So the bladder stones or bladder calculi may develop in an obstructed bladder. Bladder calculi form most commonly as a result of outflow obstruction, residual urine, and stasis and infection. These are the changes that will happen to the bladder. Regarding the upper tract, hypertrophy and fibrosis of the detrusor wall increases the work required to transport the urinary bolus from the ureter into the bladder. This will lead to dilatation of the upper tract and bilateral hydronephrosis. In the early stages, the conditions appear radiologically as mild dilatation of the distal segment of the elongation and sometimes tortuosity of the ureter. What are the clinical features of BPH? BPH will manifest in the patient in the form of decreased force and caliber of urinary stream, and which present as the first and most frequent symptoms. Also, the patient may complain of frequency. The normal frequency at daytime is less than 8 times, that is 7 times or less in the daytime. And for adults aging more than 30 years of age, nocturnal frequency should be less than 2 times at night, يعني مرة واحدة أو أقل. At first, nocturnal frequency starts the patient being obligated to get to micturate at least twice during the night. Frequency occur because the patient cannot empty the urinary bladder completely. So residual urine will get the bladder to get filled quicker than usual. The other symptom would be urgency. When the vesical sphincter becomes stretched, a little urine escapes into the normally empty prostatic urethra, causing an intense reflex desire to void. Another symptom is hesitancy, which is difficulty in initiating the urinary stream. Patient cannot start micturition, or the starting of micturition will be delayed and difficult. These may be accentuated into acute urinary retention and إذا صار في انقطاع حاد بالبول هذا نسميه acute urinary retention, as opposed to chronic retention with overflow or incontinence. بدل ما المريض مرة واحدة يصير عنده احتباس وينقطع البولة، المريض كل ما يفرغ يبقى residual volume, and this residual volume will build up in the bladder, leading to decompensation and filling of the bladder, increasing bladder capacity and myogenic failure. العضلات مال المثانة ما لها القدرة انه تدفع اليورين خارج المثانة. يتحول المريض بدل ما انه عنده، المريض طبعا ما يحس انه عنده ريتنشن، يحس انه ديبول طبيعي، لكن المثانة تكون بهالحالة متروسة اكثر من قابليتها، عادة اكثر من 800 مل. with myogenic failure العضلات مال المثانة تكون خربت بذاك الوقت بحيث المريض ما يقدر يفرغ مثانته. with constant dribbling، يعني المريض من يجيك ما يجي انه يقول لك انا عندي ريتنشن، لا يجي بالعكس عنده انكونتيننس، بس من تسوي له الترا ساوند يطلع البوست فويد ريزيدوال كلش عالي. So sustained bladder outlet obstruction plus hypertrophy and overdistension of the bladder may cause vesico-ureteral reflux that leads to hydronephrosis and later produce renal failure. Hematuria may also be presenting symptom with the drops of urine at the beginning of micturition or at the end of micturition. How to assess a patient with benign prostatic hyperplasia? First, we have عندنا history حكينا بيه. Next step is the abdominal examination and the general examination. In patients with a chronic retention, distension of bladder will be found on palpation and percussion, and sometimes even on inspection. General physical signs may demonstrate signs of chronic renal impairment with anuria and dehydration. The external urinary meatus should be examined to exclude meatal stenosis, and the epididymis both are palpated to looking for signs of inflammation. Digital rectal examination in BPH. The posterior surface of the prostate is smooth and convex and firm. The rectal mucosa can be made to move over the prostate, whereas hard and nodular prostate gives a suspicion of malignancy. A brief neurological examination should be done when appropriate. The nervous system examination is to exclude neurological lesions. Patients with diabetes mellitus, with tabes dorsalis, with multiple sclerosis, Parkinson's disease, and other neurological states may mimic a picture of prostatic obstruction. Examination of the perineal sensation and anal tone is useful in detection of an S2 to S4 coda equina lesion. This is the American Neurologist Association symptom score, AUA symptom score for prostatic hyperplasia. There are multiple symptoms examined with history taken. For each symptom, a score from 0 to 5 is given, and another separated score is taken for quality of life. If the patient have to live with his prostatic problem. Now, going to the investigation. How would you investigate a patient with suspected benign prostatic hyperplasia? First of all, urinalysis or general urine exam. In addition, blood examination, urea and creatinine can be performed. Prostate-specific antigen is examined. It is a blood marker or serum prostate-specific antigen. It is extremely helpful marker in the diagnosis of prostatic carcinoma, which may coexist with the benign prostatic hyperplasia. PSA produced by prostatic cells and related to how big the prostate is and carcinoma of the prostate is. If PSA is higher, let's say more than 4 nanogram per ml, then a transrectal ultrasound with or without transrectal biopsies should be considered. Imaging include ultrasound of abdomen and pelvis. We are looking for the size of the prostate, for the post-void residual volume, for any hydronephrosis and back pressure effect from the enlarged prostate. An IVU may be helpful. It will tell us about the renal function. Also, we have a pre-request for IVU. We mentioned it before, which is a normal renal indices and absence of allergic to contrast. If there is, it will show us, tell us about the renal function. It will show us if there is a dilatation in the upper tract, and shows the bladder, picture of the bladder, and whether there is trabeculation or not, any filling defect due to prostatic enlargement, and also show the post-void residual volume. This will not show how much, this will also show how much a residual volume will be in the bladder. Another sophisticated test is a urodynamic study in the form of uroflowmetry and cystometry. This is done if you suspect atonic urinary bladder when a clear diagnosis has not been reached. A more invasive investigation is the cystourethrogram. It is a mainstay in the diagnosis and should be performed on patients with hematuria. The urethra is inspected first and the bladder is then examined to see trabeculation, stone, and diverticulum. It should always be made before prostatectomy. How to manage patients with benign prostatic hyperplasia? The lines of treatment starts with medical treatment. Medical treatment in the form of alpha blocker drug. The prostate contains smooth muscle that's controlled by alpha-1 adrenoreceptors, and alpha blocker agent have, when blocking the alpha receptors in the prostate, dilatation of the prostatic muscles facilitates the urine flow. Nothing comes without a side effect. So side effects of alpha blocker can be a postural hypotension, tachycardia, palpitation, and a retrograde ejaculation. Example of alpha blocker are phenoxybenzamine and prazosin. These are the less selective and the old version. Now we are more toward the use, also endoramine. Now we are more toward the use of alpha-zocine. Tirazocine is also one of the old version, but alpha-zocine, doxyzocine, tamsulosin, and silodocine, these are the newer versions. The selective are tamsulosin and silodocine. Androgen, another line of treatment is androgen suppressant. The rationale of androgen suppression is observed is an observation that the embryologic development of the prostate is dependent on the androgen dihydrotestosterone. Testosterone is produced mainly by the testes and to a lesser extent by the adrenals, and testosterone enters the prostatic cells and converted into an active component dihydrotestosterone by the enzyme 5-alpha reductase, and the enzyme can be inhibited by drugs like finasteride and 5-alpha reductase inhibitors. A 5-alpha reductase inhibitor. There are two 5-alpha reductase inhibitors. First one is finasteride, the other one is dutasteride. Finasteride is more selective, dutasteride is less selective. 5-alpha reductase will decrease the size of a prostate by 10 to 20%. Median lobe have poor response to androgen suppressants. Another option in management is the surgical treatment in the form of surgical removal of the prostate. The options are first, open simple prostatectomy in the form of transvesical or retropubic prostatectomy. retropubic يسموها ماتينا Millen's prostatectomy. This is an open surgical method. The gold standard for prostatic surgery is transurethral resection of the prostate, TURP. Another option is a transurethral incision of the prostate, which is used for smaller fibrosed prostate. There are also a minimal invasive techniques for prostatectomy, including transurethral microwave therapy, transurethral needle ablation, photoselective vaporization of the prostate, holmium laser enucleation of the prostate, and holmium laser ablation of the prostate. The problem with the recent methods, the minimally invasive methods, is that they do not give us a sample for histopathology, because they either evaporate or ablate the prostatic tissue. What are the indications for prostatectomy? The indications include acute urinary retention, marked hemorrhage from enlarged prostate, persistent or recurrent UTI, renal impairment as a result of bladder outlet obstruction, and persistent lower urinary tract symptoms not responding to medical therapy. When to do open prostatectomy? It is indicated when the prostate size is more than 75 grams, although after the introduction of bipolar TURP, transurethral resection in saline of the prostate, or bipolar transurethral resection of the prostate, the size of the prostate is of less prediction of the type of operation. But with unipolar transurethral resection of the prostate, it is relatively contraindication if the size of the prostate is more than 75 grams. So, for open prostatectomy, if the size is more than 75 grams, if there is concomitant bladder diverticulum that have to be dealt with open surgery, if there is a large bladder and hard bladder stones that cannot be dealt with transurethral. Also, marked ankylosis of the hip that prevents proper placement of the patient in dorsal lithotomy position for cystoscopic approach. Open prostatectomy is contraindicated if the prostate gland is too small and if the patient have history of TURP, patient with prostate cancer, or with the previous pelvic surgery preventing access to the prostate gland. Post-operative complication of prostatectomy include local complications such as excessive hemorrhage, perforation, urinary extravasation, infection in the form of cystitis or epididymolysis, urge or stress incontinence or both, retrograde ejaculation and impotence, and bladder neck contracture. These are the local complications. The general complications may be in the form of DVT, pulmonary embolism, water intoxication, what is termed as TUR syndrome, and hyponatremia. هذه نهاية محاضرتنا لهذا اليوم. شكرا لاستماعكم للمحاضرة. اللي عنده أي أسئلة ممكن يتواصل وياي على كلاس روم أو على تليفوني الموجود نزلت على كلاس روم، تطبيقات فايبر، واتساب أو تليجرام. شكرا لاستماعكم وتمنياتنا لكم بالموفقية.